Well, tonight I'm joined by Magdalena Edington, a consultant ophthalmic surgeon currently based in Optegra in the Midlands. Now, Magdalena is not someone you'll see everywhere on social media or on the big stages just yet, but within the profession, she already has a reputation for being an outstanding cataract surgeon. And that's why I wanted to talk to her. And I'm really excited to see where her career is going to go next. Magdalena, thank you for joining me.
No, thank you for having me, Simon. Very kind.
Perhaps we could start by you telling us just a little bit about your consultant career or your medical career to date.
Sure. So I studied medicine in Poland in the English division. So I had the privilege of studying with people from all over the world, which was lovely to sort of get an early experience of how medical systems and different specialties work in different countries. I knew I wanted to do surgery from pretty early on, but I was toying with general surgery. So I was in a surgical society during med school, where if you had the opportunity to shadow consultants on call and assist in theatre. And obviously, as with most things, the more you put in, the more you get out of the experience. So by my final year, I was doing almost full cases under supervision. And I assumed that when I moved to England, that would continue. And then I had the experience of starting foundation training in Oxford and realizing I wouldn't see the inside of a theatre for a very long time. I was rewriting drug charts and reciting Venflons all day long. Um, so that was the first sort of, okay, maybe this isn't going to go according to plan. And also the system's very different. So, you apply for general surgical training, which will, if you get in, then you're probably sent to a different part of the country. And then 2 years later, you have to apply for specialist training, which again is even more competitive, and you may or may not get the job that you want. And if you do, you're probably going to be sent to a different part of the country. And I just felt really disillusioned with my career prospects. But I had heard a lot of good things about ophthalmology, and I think the sort of disappointing thing with medical school is you get very little exposure to some of these subspecialties. I think in medical school we had 2 weeks of ophthalmology, all of it lecture based, and so you can't really get a feel for some of these specialties, which are actually fantastic. So I had heard good things, and it was obviously, as you would expect, the very last job of my foundation training. So you're meant to apply for jobs in February, and I wasn't starting ophthalmology until April. But I thought, if I don't give it a go, I will probably regret it. And I'm so glad I did, um, because I really did. I found it fascinating from day one. Um, some interesting stories from the JR. I mean, there's very little hand holding. I can say that. My very first day, very first clinic was VR and genetics clinic with Professor Robert McLaren. So I remember very timidly knocking on his door, introducing myself and going, "Well, I've never seen a slit lamp. May I please sit in your clinic?" And he said, "Absolutely not. There's your room. There's your slit lamp. Come back when you've seen the fundus." So I'm very grateful to that first patient. Um, Probably 40 minutes later, I finally got a glimpse of something at the back of the eye. But I was so proud. There's no going back. Um, and at the end of my foundation rotation ophthalmology, I obviously didn't have a job. So I went and spoke to the department and just said, are there any projects? Is there anything I can do? And Victor Chong gave me the opportunity. He said, well, we're very short in casualties, so you can be my honorary research and clinical fellow. Hop right in. Again, walk-in casualty, 50, 60 patients a day. So very steep learning curve, but it got me my first publications. And it just meant that when I finally did get my run-through training in West of Scotland Deanery, I had the basics down and I could focus on other things. I think I have to say a little bit about West of Scotland. I mean, it's such a fantastic training program, lots of opportunities. And, I was so lucky with the people that I met. I went through some quite difficult times on the personal front during my training, and my colleagues were so supportive. The consultants were so fantastic. I really couldn't have made it through without all of them. So thank you for that. Throughout training, I was really medical retina based, based on my research from Oxford, and I really enjoyed uveitis. Again, fantastic team. But I had the opportunity towards the end of my training to do the first TSC in high volume cataract surgery at the Golden Jubilee. And much the same as with the F2 rotational ophthalmology, 1 week in, there was no going back. This is what I wanted to do for the rest of my career. So I stayed on at the Jubilee as a consultant after finishing training. I was appointed training lead, and along with John Ellis, we set up the first immersive cataract training program in Scotland, which was highly successful and still going strong today. And I think that's really changed the way we approach cataract training in Scotland now. And then 2.5 years ago, I moved to Leicestershire with my family and joined Optegra, which has also been a very different, very, very fantastic, really, experience, challenging in its own ways. Last year, I was a lead consultant for the Midlands. So I was overseeing 4 sites, 2 of which were brand new sites. So that really sort of broadened my horizons in leadership and management and just clinical governance, all of those things that we don't really get exposed to very much during training. And I've just recently started a new role at Optegra as their training lead for Optegra UK. So hopefully a busy year ahead.
Well, congratulations. A wonderful career so far, and great things await you, I'm sure. Now, look, you've got a reputation as a truly excellent cataract surgeon. How would you describe what matters most to you during surgery itself?
I think the most important thing is to approach every patient, every case as an individual manner to make sure that you have the information, that not only have you assessed the patient appropriately, but you understand what is important to them. And that's both from visual outcomes, but also, during surgery. Surgery can be such a scary experience for people, and they have anxieties, and just doing something very simple like offering a clear drape or a hand holder or just talking them through the surgery or not mentioning the surgery at all, but talking about holidays. It's just really understanding what makes that person tick and making that experience a safe and sort of memorable one for them, because it's so important. From surgery itself, I think the most important thing is staying calm and not rushing. It is high volume. It's not about being fast. It's about being efficient. So just making sure that you're doing all the steps correctly to the best of your ability, and that's what creates the flow and that's what creates the efficiency.
And for us mere mortals, what do you mean by high volume?
So on an average list, we do between 27, 29 cases in a day.
That must leave you pretty tired by the end of the day.
That's why I work part time.
Would you want to be patient number 29 on that day?
Absolutely.
Good.
You, as I say, treat every single case as a brand new case. And I think you have to, you build up that stamina. I think when I first started, you don't start doing 29 cases from day one. You start at 12, you feel comfortable, you build up to 16. And you do, nobody will ever force you to do something that you're not comfortable with. So there are surgeons whose high volume is 22. And there are surgeons, I think, Java Moedi does 30. And I think 28 is a comfortable pace for me. Make sure that the team gets breaks in between as well, and we're not just sort of pushing through. But it's really important to just clear your mind. After every case, you reset and you give that next patient the exact same level of care that you would give patient number one.
Very sound advice. And for people who may not know you yet, what sort of surgeon are you in theatre?
I think I'm quite relaxed most of the time. We always have music playing in theatre. I quite like to get to know my patients, get to know my team. I think the only complaint I had when I was at the Jubilee is I was overly exuberant, which I thought was a strange thing to say. I'd like my surgeon to be exuberant and love their job, but again, it's about understanding, what that patient wants. If they want complete focus and seriousness, because otherwise they don't feel like, you're giving them your full attention. I'm always focused, but sometimes I hum under my breath or I'll say a joke, and usually that puts people at ease and they quite enjoy that.
Yes,
But again, you just have to be careful and again give patients what they need to feel good about their surgery.
absolutely. The bespoke approach is very important, isn't it?
Mhm.
So which part of cataract surgery do you think requires the most judgment rather than just technical skill?
I think every step of surgery, because things can change so quickly. Often it's the super sort of challenging cases where all the odds seem to be stacked against you that, go smoothly and no problems. And then it's the seemingly straightforward cases that something unexpected happens. And this is where, I always tell my trainees, you have to do every step to the best of your ability, because if you sort of don't take care with the first step, then all the other consecutive steps are going to be more difficult for you. I think probably doing a really good rexis, that center, that's the right size, that isn't going to tear out, that really sets you up for good, safe surgery.
And what still makes you pause and concentrate, even now during surgery?
Um,
What
I'd
scares
like what scares me. Nothing. Nothing scary. Um,
you?
I think I often get asked what makes me hold my breath, and I would say nothing, because that's the first piece of advice I give to trainees. Don't hold your breath. And you can often see with new starters who, you can see the moment where they start holding their breath and their shoulders hunch up and they get the little T-Rex hands and they're
Yes.
pressing on the wound. So I would definitely say, don't hold your breath. And that's even more important when things are not straightforward and things, potentially are deviating from the norm. It's so easy to get into that panic mode where your mind goes completely blank, your palms are sweating, your heart is racing, and all you want to do is for it to end. And the instinct is just to power through and finish as quickly as possible. And most of the time, that's absolutely the wrong thing to do. Take that step back, assess, and know when to stop. I think one of my mentors, David Lockington, told me early on, a good cataract surgeon knows when to operate, a great cataract surgeon knows when not to operate, and equally when to stop. And that's really sort of stuck with me through my training, through my career. I think zonulopathy probably makes me a little bit, makes that heart rate go up a little bit, particularly those cases where maybe something's been missed, the patient's been asked about trauma and they've said no, and you're trying to start the rexis and nothing's happening, and you're going, are you sure? And they're like, well, I've been punched about 3 times, but that doesn't matter, does it? And you're like, that would have been really great to know before you came. So I think, yeah, that probably makes my heart race a little bit, because things can sort of deteriorate quite quickly. And again, you want to make sure that you're working within your limitations. And that is not only your surgical limitations, but often we're limited by, the equipment that we have, depending on where we're working. So I always love going to conferences and seeing these fancy surgeries, and well, you can do this and you can put in 260 degrees capsule, zonule dialysis. That's fine. We'll put in 3 rings. We'll suture them to the sclera. And I go, well, I don't have that available to me. So again, just knowing when to say, actually, we need to call in reinforcements and get that support to make sure the patient has the best outcome possible.
Now, you've had a lot of exposure to dropless cataract surgery working with an Optegra. Can you tell us a little bit about the technical details there? What are the key steps that you do that make dropless cataract surgery work well? Because there are lots of skeptics out there at the moment.
I think the data is now there. So as far as technique, I personally do a subconjunctival triamcinolone injection, trying to get it, a good 6 millimeters from the limbus, but it's not always possible. It's I know that most people worry about pressure spikes, but actually, the dropless, we're not saying drop free is for every single patient. You have to select your patients appropriately. So patients who are higher risk of pressure spikes, like glaucoma, ocular hypertension, steroid responders, they shouldn't be getting dropless. They shouldn't be getting a steroid injection. But we've done over 11,000 cases now, and we're going to publish results soon, I believe. But actually, if you select patients appropriately, the risk of pressure spikes is very low. And the CMO rates are comparable, if not lower, than with drops. So in today's world where there's such an emphasis on efficiency, on cost effectiveness, on reducing our carbon footprint, I think drop-free is going to be the way forward. And it's been really reassuring seeing the recent guidelines from UKISCRS, and hopefully as we start getting more publications, the EPICAT study, Optegra's data, I'm hoping that will reassure those people who maybe don't feel comfortable with that technique yet. But I would say is that change is scary. So every time we deviate from what we're used to, that's going to make us uncomfortable, and that's okay. That's normal. But I think as long as the data is there to back it up,
Out of
progress.
interest, with diabetic patients and those with epiretinal membranes who we would normally offer non-steroidal anti-inflammatory drugs topically, do you give those as an injection as well, or do you send them home with Acular, for example?
No, so actually, I've not been sending them home with anything, and we've not seen a significant increase in CMO rates. So working in my population in Birmingham and Leicester, we've got a huge incidence of diabetes, quite a lot of membranes as well. So I did feel a little bit worried that these patients might present with a lot more inflammation and swelling. But so far, that's not been the case. I always explain the risks prior to surgery. Say, you are higher risk of developing macular edema. Um, Chances are you'll be absolutely fine with just the injection. I do say we can give you drops if you would like them. So if you'd like additional 2 weeks of ketorolac, that's absolutely fine. But the majority of patients say, no, I'd rather risk it and not have any drops. And most of them are absolutely fine. Of course, some do come back, and then you can treat them with the top of drops or an additional subtenons steroid later on down the line if required. But so far, so good.
And a boring question, what's the dose of triamcinolone that you give at the end of the surgery?
So we give 0.4 of mils of the 10 milligram solution. So as per the studies, the most efficient dose.
Fantastic. Now, if you weren't doing ophthalmology, and I know you love cataract surgery, what do you think you'd be doing instead?
I wanted to be a teacher when I was young, and I'm sort of doing that still. So I'd probably go into teaching more formally.
And thinking of your mentors themselves, what's the best piece of advice another surgeon's ever given you?
I think the most reassuring to a trainee is everyone has complications. The people who don't have complications either aren't operating or are lying. And that, as a trainee, I think that was such a reassuring thing to hear. I think now we're a lot more open. You go to conferences and people show you, their nightmare cases, and they're very open about things that happen. When I was training, it was rare for somebody to openly say, well, I had a PCR last week and it was an awful experience and this is what I learned. So you kind of went through training thinking you were the only one. You were that person who was, having issues. So that was reassuring. But also as a trainee, I think knowing that if managed appropriately, most patients with complications will still have fantastic outcomes. And I think that's what we worry about the most is, not doing harm. And when you do have a complication, even a minor one, your heart just sinks and you feel so terrible as a surgeon that this has happened. And it might not even be something that you've done, but something unexpected has happened in theatre. The patient's coughed and things just haven't gone to plan. But you still, you take that home with you. You think about it. You relive that surgery, and you see what could I have done better, and how can I make sure this doesn't happen again. So it is a huge burden. So I think probably from that side of things, just normalizing that, but also knowing, make sure you have A, you're working within your limits, and B, you have the backup plans, because that's what's important in surgery, thinking on your feet and knowing what are you going to do if plan A doesn't work out.
Of all these wonderful surgeons that you've worked with over the years, who's influenced your surgical style the most, would you say?
Oh gosh, that's difficult because as a trainee, I made it my mission to do things exactly the way the boss did it. And that sometimes put me outside of my comfort zone. So for example, with John Ellis, I started chopping, which I had never done before. And it was awful and it slowed me down. And until I got the hang of it, I absolutely hated it. But I made it a point, and that's what I encourage trainees to do, is do things exactly the way your boss does it. Because even if it makes you uncomfortable, first of all, it will build a better rapport with that person because they'll feel more confident in letting you do more steps of surgery because they know exactly where you are, how you've done it, and they can take over seamlessly. But also learn as many techniques as you can, because Then when you get into the most challenging cases, you have unexpected things happen, you can rely on those techniques rather than panicking, going, oh, this is the first time I'm going to chop now under pressure. You don't want to be in that situation. So it's hard to say who's influenced me the most. Gosh, it's really, really difficult. I'd probably say Mike Gavin because I did my very first surgery with him as an ST1.
Yeah.
So that's probably quite a memorable moment for me.
And if you had a cataract yourself tomorrow, who would you choose to do your operation for you?
Oh, that's so unfair. um, I think it depends where I am, whether I'm in England or Scotland or abroad, because I've met so many
I,
amazing
I,
cataract
I, I
surgeons.
think you're in Leicester at the moment.
I've only just moved down. I don't actually know any surgeons in Leicester except me, myself and my colleague Fadi Al-Fakawi. So it'd have to be one of us. But no, I've been so lucky to work with incredible surgeons, and I know I would be in very good hands no matter where I went. But I would like to think that by the time I need cataract surgery, all of those amazing people will be very happily retired on a tropical island somewhere. And I think this is where training comes in for me. I very selfishly am always on the lookout for new talent in the younger generation. And for those people who don't feel that training is a priority, I would say, well, remember, these are the people who'll be looking after your eyes. So it absolutely is in your best interest to make sure they are the best they can be. So invest in the trainees.
Magdalena, it's been the most wonderful half hour chatting about cataracts. I hope you've enjoyed yourself and thank you for coming.
Thank you very much for having me.